My name is Lori Facciarosa Brewer, and I am the State Long-Term Care Ombudsman. And the Ombudsman Office advocates for residents of long-term care facilities by investigating allegations of abuse, neglect, and exploitation. And we also do quite a bit of policy work and input on legislation. I'm really excited about the program today, and I thank you all so much for signing on. I think it's going to be very interesting and informative. This is obviously a very difficult time for everyone working in the long-term care space. It has been for going on 2 years. This is a difficult time for the people working in long-term care facilities, so I really want to acknowledge the heroic work that they are doing. And certainly we always need to keep close to our hearts and in our thoughts the residents of long-term care who have suffered so greatly over the last couple of years and the many thousands of souls that we have lost. The fact is that there is just a continual wave after wave of COVID-19 coming into the system. The impact on long-term care facilities has been devastating, and it has certainly revealed some of the weaknesses in the institutional long-term care system. So I'm going to be talking today a little bit like the institutional side, which are the facilities, the nursing homes, and then there's, of course, the home and community-based side of long-term care, where you receive services in your own home or in the community. It's clear that COVID-19 has demonstrated to us a need to reform this system. And in the 2 years since COVID-19 began, the state of New Jersey really has done some remarkable things. They've taken some actions to try to both support long-term care facilities and to reform the institutional system. In the last year, the New Jersey legislature has passed and Governor Murphy has signed legislation that increases Medicaid funding and earmarks those funds for direct care staff and also for infection control and to help those long-term care facilities absorb the increased costs that were tied to COVID-19 pandemic. Legislation creating minimum direct care staffing ratios, which we had been pushing for quite a long time. Legislation increasing financial disclosures for individual nursing homes, legislation creating more transparency around the ownership of nursing homes, and a direct care ratio bill. It's basically called a direct care ratio bill that requires that 90% of all Medicaid funding that a nursing home receives has to go toward patient care. Excuse the background. And New Jersey has put forward a very ambitious, on the home and community-based side, a very ambitious plan through the state Medicaid agency to increase home and community-based service to really strengthen that system, and even has included some efforts to increase housing, accessible and affordable housing for people who might wish to be leaving nursing homes or who never want to go into a nursing home in the first place. So we should be very proud of these accomplishments. They really are a great start. I should mention that the state has also impaneled the New Jersey Task Force on Long-Term Care Quality and Safety. I am a member of that group. It's meeting now to develop recommendations to make improvements in long-term care facilities and to create more and better options for residents to age in place in their home and community-based settings. So both of these systems receive significant public funding through Medicaid and through Medicare. And so when you're talking about reforming the long-term care system, it's really important that we as policymakers have a very good handle on how those public funds are being directed and spent. So in that vein, I'm very pleased to have Ernie Tosh. I'm so glad that he agreed to come to New Jersey, at least virtually, to be with us today, to share the information that he has gleaned during his many years as an attorney who limits his practice to nursing home abuse and neglect. He is also a lecturer on forensic accounting in nursing home litigation. And as a result of this work, Ernie, who is a former prosecutor, has become a national expert on the relationship between nursing home finances, staffing, and resident care. And that's what we're all about. We're all here and we're all about that. I first heard Ernie speak at the National Consumer Voice Conference last year. I think you will find that he has a good way of explaining things. I had many an aha moment when listening to Ernie speak at the National Consumer Voice Conference. So I'm going to hand it over to Ernie. Ernie, take it away.
Thank you. As she introduced, I'm Ernie Tosh. I'm an attorney from Texas. I'm licensed in several other states, and my legal practice is specifically elder abuse, where we litigate those cases around the country. I got into this work about 10 years ago, and because of my undergraduate work, I have a degree in finance with significant hours in economics and accounting. I started looking at cost reports and started figuring out how the numbers played into the healthcare. And over time, did more and more research on that, wrote some computer programs to help me do analysis of all this information, and have actually been an expert in a number of these cases as they've gone forward in the legal system. More recently, I've been working with state attorney generals, both in New Jersey and California, in investigating fraud and prosecuting fraud within the long-term care sector. Today, I want to talk to you guys about a couple of things. Private equity investment, because that is something that is kind of in the forefront right now. And I want to explain what that is briefly, but that's not the focus of today's discussion. Private equity investment has had a detrimental effect on long-term care. I actually will make the PowerPoint that I'm showing you today available through the Ombudsman's website, but the one that's going to be available is actually a longer format than this one because there's a lot more information on private equity, but we wanted to pare that out of this presentation because I didn't want to consume all of our time talking about private equity. But I did want to explain what it is because it is out there in the forefront today, and it does play into the second part of today's discussion, which is going to be about how the current financial reporting tools that are in place both at the state level and at the federal level do not capture the actual financial state of the nursing homes, and that they can be significantly manipulated to show whatever the chain wants us to see about that facility. So we'll get into that. I'll explain how that works, how the manipulation works, and ultimately what can be done to change the system so that we have better transparency. Because as Laura said, the two biggest reporting issues that we have within long-term care concern who owns the facility, because we oftentimes don't have any idea. And secondly, are they actually profitable or not? And that becomes a big point when deciding if we need to increase reimbursements or not. Because if the facility is fabulously profitable, then why would we continue to increase reimbursements, especially when their care standards are so low? So let's get involved in this. You can put questions up in the sidebar. There's a little question section over there, and we're going to have at the end of the presentation, we're going to go through some of those questions, and I'm going to try to help you. Also, at the end of this presentation is my contact information, my telephone number, my email address. Feel free to contact me after the presentation if you want to discuss more about this. If you've got questions that don't get answered, please let me know. I'll be more than happy to help you with this stuff. So, as I stated, one of the biggest problems with long-term care is transparency. Transparency as to who actually owns the healthcare provider, and then also, is the healthcare provider profitable or suffering a loss on an annual basis? With that, we would also need to know, is the intermediary company profitable or losing money? And is the parent company? Because as you'll see in this presentation, we have multiple layers of entities or companies that own each other. And you can make the lower level company, which would be the nursing home, appear to be losing money, but the intermediary company and the parent company may be making fabulous profits. So ownership transparency, why is this important? Number one, the funds that are being paid through Medicare and Medicaid are US taxpayer dollars. We as taxpayers have a right to know where our tax money is being spent. And not just that it's being provided to the nursing home up the street, but who is that money going to after it clears that bank account? Secondly, are the owners and individuals or the corporations that are owning these nursing homes, should they in fact be healthcare providers? Because as some of y'all know, if you are found to have engaged in fraudulent activities within the Medicare Medicaid system, you can be disqualified from being an owner of a facility for many years into the future. Well, if you use specific investment tools such as private equity, you could skirt those rules and actually become an investor in a healthcare company again, and nobody would know that. The other thing that ownership allows us to see is if one or more companies are exerting monopolistic control over a market. Because you may have a market that has company A who has 10 nursing homes and company B who has 14 nursing homes. And you think, okay, we have some competition in the market. Well, if you only know one level of ownership, which is A and B, you don't realize that company C owns both of them and that you actually don't have any competition. That is an illusion of competition. And in fact, you have a monopoly in that area. So again, you need to understand ownership all the way up to the very top parent company. Financial transparency, as we stated before, you've got the healthcare provider, which in the long-term care setting is the nursing home. You may have an intermediary company that owns it, which is then owned by a parent company. And we need to understand, are they making money or losing money? Why is that important? Well, because as you all know, the long-term care industry makes a tremendous habit of arguing that they are constantly in need of more federal and state money. Well, we don't know if they actually need more money or not. They claim they do. They have been extremely good at voicing that in the public sector to every microphone and newspaper and internet outlet that will broadcast it. Their message is far and wide. We are broke and we need more money. Unfortunately, we don't know if that's true, okay? The fact of the matter is, it may not be a reimbursement problem, it may be a utilization problem, meaning that they are not utilizing the money for health care that they are being paid, that they are in fact profiteering and just skimming tremendous sums of money off to the ownership, and the long-term care patients suffer from that. Now, in discussing private equity briefly, we need to discuss traditional ownership. What is traditional ownership? Well, there's two types of traditional ownership. There's private ownership. This is like an individual, a single person who owns one or more nursing homes. They have direct control of the assets. They are not traded on a stock exchange. The ownership can be somewhat opaque, depending on if they layer companies to hide who the actual owner is. The owner takes all the risk and all the profits go to the owner. Okay, that's unfortunate. And I've shown here on this slide, the opacity in ownership is where we talk about there's limited ownership transparency. There's no financial transparency because we don't actually know if the nursing home and the overarching parent company is profitable. And so there is no financial transparency. We have public sector. These are companies who are publicly traded on a stock exchange. They have direct control of the assets. They take all the risk and distribute the profits to the shareholders. The ownership is fairly clear because they are a publicly traded company and their finances are very transparent because of the SEC filings that have to be filed by publicly traded companies. So unlike our private companies, our private individuals, and our private equity investors, public sector has to file extensive financial statements that give us full transparency. Now, what is private equity? Private equity is not traded on a stock exchange. It is opaque, so there's no ownership transparency unless you are part of the private equity group, in which case you may know who some of the other investors are, but not necessarily. The private equity company generally has control of the investments. It takes some of the risk, but it makes all of the profits, and there is no financial transparency. Within the healthcare sector, I've thrown this slide in here, not going to read it to you. You can go back and read it later if you want to. What it basically says is that over the last 10 or 12 years, private equity has been pouring into the healthcare sector, not just nursing homes, but hospitals and clinics, et cetera. Huge transactions, buying up healthcare providers using private equity. So how do private equity firms operate? Basically, they pull capital, so they collect money from a set of investors. Again, we don't know who the investors are in most of these transactions, and they commit that investment to a fund. So that fund then goes out and buys one or more companies. The fund grows the cash flow of that purchased company and then sells that purchased company and keeps a portion of the profit within the private equity group. I mean, it's management gets a percentage of that as their management fee, and then they distribute the rest of the proceeds to the investors. Big private equity companies can have multiple funds within them. You could have them, a big group could have a fund that purchases nursing homes, a fund that is in the dental industry, another one that purchases hospitals. So some of these private equity funds are massive. So to see this depicted pictorially, we have Blackbeard Investments. It's our private equity group. It owns a company called Southern Mega Healthcare. And through Southern Mega Healthcare, they go out and buy 3 nursing homes: Grapevine Nursing Center, Memphis Nursing Center, and Atlanta Nursing Center. The nursing homes As they generate profits and revenue, that goes up to Southern Mega, and those profits are then realized by Blackbeard Investments. What do private equity firms do in the long-term care market? They invest in companies. They go out and buy nursing homes. They then try to grow the cash flows for 4 to 7 years. They try to grow revenue, meaning they try to increase their census. They may try to go out and get higher acuity patients. They will buy up competitors in the same market space, and they will cut expenses. And the reason that I have highlighted cutting expenses is cutting expenses is basically code for cut staffing, because staffing is the highest expense within the long-term care sector. And if you cut staffing, you can increase profitability directly. The hope is that after 4 to 7 years, they will either sell off the assets that they have purchased. So Southern Mega Healthcare with all its nursing homes would be sold off as a block at a premium because it's now highly profitable, or it can be taken public and become a publicly traded company. And when it goes from private to public, that's basically a sell to the public, and all the proceeds would then go to Blackbeard Investments. Now, you may be asking yourself, okay, what's the difference between traditional ownership and private equity? Because that sounds very similar. You buy a company, you want to increase its cash flow, and someday you may or may not want to sell it, but it sounds similar. It is similar with two big differences. Number one is the fact that the time frame of interest is so limited, 4 to 7 years, okay? In a traditional investment, traditional ownership, companies or individuals are buying nursing homes and they're keeping them for decades, okay? They are looking at long-term growth and long-term investment, and what is the long-term effect of what they are doing with that company. Private equity doesn't care about long-term. Private equity only cares about 4 to 7 years, and then they're cashing out. They do not want to be in the business for longer than 4 to 7 years. So their selling of the company is the second thing. It is they are going to cash out and be gone. So as you can imagine, they do not have an incentive to create long-term wealth or a long-term model that is successful. They are looking to maximize profits for the short term, and they will absolutely do it at the expense of long-term. Private equity's singular focus is to double or triple its investment in 4 to 7 years. So what does that mean for patient care? Means that they're reducing staffing to reduce expenses, and they're filling the beds even when they don't have adequate staffing. They're going to have an over-reliance on unlicensed staff to reduce their labor cost. They're going to have a failure to provide adequate training, which also leads to much higher turnover, which gets into a vicious cycle of inadequate training, more turnover, and more issues with healthcare. There's going to be pressure on physicians to provide unnecessary and potentially costly services. This is not so much something we see in long-term care nursing home setting, but it is something that we see in the hospital settings and in private sector service. And then you have violation of regulations required for participation in Medicare and Medicaid, such as anti-kickback provisions. And there's the creation of litigation risk. And creation of litigation risk is not only for anti-kickback provisions or we call key TAM cases, which are fraud cases brought by the federal government or a state AG's office. It's also creating litigation risk as private individuals, the patients, are becoming injured. you're suffering more falls and more pressure injuries and more severe infections because they've cut the staffing so severely, and they are going to get sued for that. And so they're creating litigation risk as they try to maximize their profits. There was a great paper that was published last February, actually almost a year ago now, that I've cited at the bottom of this slide. If you haven't had an opportunity just to go read it, it's a fantastic paper by Dr. Gupta and Dr. Howe primarily. They looked at private equity ownership and found that in the short term, mortality of Medicare patients increases by 10%. Okay, straight language, that means that you have a 10% increase of killing Medicare patients if the facility is owned by private equity. You have average staffing levels decreasing. You have pain increasing, and at the same time, patient mobility decreasing. And the probability of taking antipsychotic medications is increased by 50%. Why is that? Well, those of us who are close to the long-term care industry understand the easiest way to get somebody to be compliant and to stay in bed and not cause you problems is to put them on antipsychotic medication and basically chemically restrain them. It is illegal, but it is very effective. The other thing we see financially is that management fees increase by 7.7%, lease payments increase by 75%, and debt interest payments increase by 325%, which decreases their cash on hand by 38%, meaning that there is less money for patient care. And I explain all three of these mechanisms, management fees, lease payments, and interest payments in my longer PowerPoint presentation. I actually get into some detail as to how those mechanisms work in the private equity sector and why they are so detrimental to the long-term care sector. But we're not going to go into all that detail for this presentation. Private equity acquisitions have actually increased during the pandemic. As you can see, in 2019, there were 33 acquisitions. Total value was slightly under $500 million. In 2020, 43 acquisitions, and it tripled the value to $1.5 billion. So private equity is in the long-term care sector, and it is detrimental. You may ask yourself, well, you know, we hear nursing homes operators are going bankrupt. Well, guess what? Private equity can actually bankrupt a company and still make money off of it. I also explain that in my other PowerPoint. But you have to ask yourself, why would private equity continue to invest in an unprofitable industry? And I say unprofitable because that is what the industry has been projecting for the last few years. We need more reimbursement. We need more Medicare and Medicaid or money. We are losing money. We are going bankrupt. Number one, I think most of those bankruptcies are not due to reimbursement issues. It's due to poor asset management, again, which I've explained in a longer presentation. But you have to ask yourself, why would private equity invest in an unprofitable industry? It wouldn't. Okay? Private equity's sole purpose is to maximize returns on investment, doubling or tripling their money every 4 to 7 years. They would never invest in a losing industry, which should set off red flags everywhere when they stand up and say we need more reimbursement, because they wouldn't be here if it wasn't already fabulously profitable. They are begging for money on a daily basis, claiming that they're losing money, but there is no financial transparency, so we don't know if they're losing money or not. Okay, that's one of the things we need to fix. Because, again, the question, do they need more reimbursement or is it a utilization issue? We can't answer that question right now. We keep, as a society, throwing money at nursing homes, expecting the care to get better, and it does not. We expect staffing ratios to go up. They do not. Where's the money going? We don't know. So let's turn specifically to nursing home finances. Okay, this is, I put on this slide, private equity in action, but I'm not going to limit it to private equity. We saw these issues within the nursing home sector more than a decade ago when I first got involved in this. That was before private equity was doing anything in the nursing home sector. This has been an ongoing issue for 10 or more years. It's just become exacerbated once private equity got involved. The way these chains are set up, it's all built up around related parties, okay? What related parties are, it's companies that are related to each other through common ownership. If you think of it as in a family situation, a brother and a sister are related because they have the same parents. Companies are the same way. Nursing home A and nursing home B may be related because they are both owned by company C. Okay? That's called related parties. And this is a related party structure. It's actually a very simple structure as we only have 5 companies involved. We have dealt with nursing homes that have had in excess of 300 individual companies. So you can imagine what that map looks like. It is crazy. But what you've got here is our Southern Mega Healthcare. That's our company that we know from earlier is actually owned by Blackbeard Investments. But Southern Mega owns nursing homes, okay? In this picture, it owns these 2 nursing homes, Grapevine Nursing Center and Memphis Nursing Center. It also owns a real estate holding company. What this means is that the 2 nursing centers don't own their own buildings. They don't own the land that those buildings are on. The land and the buildings are held in the real estate holding company. And then that company leases them back to the nursing homes, okay? So if it were a true arm's length transaction at market value as they are supposed to be, then that would be no problem. They would be paying market rates for their rent. But what you can do with a related party is you can way overcharge the nursing homes to suck all the money in, okay? Show you how that works in a second. Management company, another common related party, and the management company oversees the operation of all the nursing homes. In exchange, it gets paid a percentage of their gross revenue. Again, it's siphoning money out of the nursing homes, and then the profit goes up to Southern Mega. So in a normal, traditional setup like this, you would have multiple related parties, not just a management company and real estate holding company. You would have physical therapy, occupational therapy, speech therapy. You probably have a pharmacy. You may have a nursing agency, which is contracting all the nurses to the nursing homes. You can have, there's one company in the Southeast that has a a interior decorating related party that it charges every facility every year for interior decorating, et cetera, et cetera, et cetera. You can have hundreds of related parties. So with that, let's look at an income statement. So we're going to look at the original income statement from Grapevine Nursing Center. And this is what it looks like. We have revenue. So we have total patient revenue. And I see there's a couple questions coming up on my side panel. I'll just let you know, I cannot read the side panel and continue talking. So I will try to address any questions at the end. I'm really sorry about that. That's a limitation of webinars for me. I like live format where I can see people raise their hand and I can answer their question immediately and make sure everybody's staying up. That doesn't really work on webinars, and I'm really sorry about that. But in our facility here, Grapevine Nursing Center, we have revenues of $16 million. We have contractual allowances and write-offs. What this is, it's basically uncollectible of 1.75 million, which means the net patient revenue, the money that got to the bank account, 14.25 million, so $14.25 million, 1 year. Expenses, $13 million. Okay, now there's a, all your normal expenses would be broken out in here, but for our example, $13 million, which means this facility had a profit of 1.25 million. So you look at the end of the day and you go, okay, they had money to properly staff, properly train, have adequate food and medicine and everything. They had the money. They had 1.25 million in profit. All right, good for them. Now, what I want to do here is show you how related parties can be used to manipulate expenses. And by doing so, we can make this number any number we want. So, going back to related parties, Grapevine Nursing Center is leasing its building from a related real estate holding company. Okay, so we use related parties to fix the income statement. So we started out, this is our original income statement, $13 million in expenses, 1.25 million in profit. And we say, okay, when we owned the building, before we were renting it, we owned it. We paid $500,000 in mortgage payments. We paid $100,000 a year in taxes. It cost us $600,000 to have that building available for us. But when it's held in the real estate holding company and we execute a lease agreement, we pay $2 million. Okay. Now, if this was an arm's length transaction executed at market value, it would not be $2 million. It would be something closer to 600,000. But because nobody is looking at these transactions, we're going to just execute it for $2 million. Why? Because we don't want the facility to show a profit. So we are going to siphon out the difference between these two numbers. We're going to siphon out $1.4 million out of the nursing home and into the real estate holding company. Okay, 600,000 was basically what the real estate holding company is going to have to pay for mortgage and taxes. That other 1.4 million is now going to be profit to the real estate holding company and an expense to the nursing home. So again, this is our original income statement. And now look what happens when we up our rent. Okay, originally our $13 million had a $600,000 real estate expense in it, but we've increased that by another 1.4 million. So now our expenses are 14.4 million. Our revenue didn't change. And now all of a sudden our nursing home is losing $150,000. Wow. Wow. That's pretty amazing. We just lost a whole lot of money. And now you know what we can do? We can now take our income statement to the state of New Jersey and to the federal government and say, look, we lost money. We need more reimbursement. And why? Because we don't know what happened to the money that went to the real estate holding company. We don't know how much money Mega Southern actually makes, because the financial statements that are collected by CMS are for the nursing homes. So this is actually a page from the financial reporting that's required by CMS. It is technically called Form CMS 2540-10. Most people just call it the annual cost report. And this is from worksheet A81. So this financial filing has about 60 individual worksheets, a lot of which are not filled out by most facilities because there's specific worksheets for rural nursing homes and stuff that an urban nursing home wouldn't fill out. But there are probably 25 worksheets that pretty much everybody probably fills out. One of them is A81. This is the related party transactions. And what we can see here is they have to identify in which category this expense comes in. So capital buildings and fixtures means this has to do with the building. It's probably rent or maintenance. And we see, okay, the expense item is in fact a lease. And then we have a bunch of home office expenses where they're billing Mega Southern is billing them for Mega Southern's expenses. And then you have a bunch of, here's nursing administration, that's probably dietary. There's a collection agency involved that the parent company owns. And what they have to disclose is what is the cost of providing that service to the nursing home? How much is the nursing home paying them? And what's the difference? And so what we can see here is the cost of providing all of this service is $2.5 million, but they're paying about $3 million, which means $449,000 of profit is leaving the nursing home and going to these related parties. And that's assuming three things. Number one, that they've reported all of their related party transactions. Not surprisingly, we often find hidden related parties. Second assumption, that they're reporting the cost correctly, because nobody audits this. Unsurprisingly, in litigation, we have found out that these cost numbers are sometimes just made up. And third, we are assuming that they're reporting what they paid the facility correctly. So these cost reports are not audited by a CPA. They are signed by somebody usually high up in the corporation, a chief financial officer, CFO, a COO, chief operating officer, the CEO, the president of the company, the owner of a smaller company. And it does contain a certification that says that under threat of civil and criminal penalties, everything contained in this document is true and accurate to the best of your knowledge. Yeah, they all sign it. But in the 10 years that I've worked with this stuff, I have found hundreds of cost reports that are complete garbage. And they've been in CMS's database for years. CMS didn't audit them. CMS didn't go back and put any type of administrative or criminal penalties on those guys for signing them. They signed them and they were garbage and unusable. That needs to change. So with the cost reports, we have several issues. Again, they are not audited and certified by a CPA. They are prepared by whoever the facility or the chain designates to fill out the form. It may or may not be a CPA, but it is not certified, and it is definitely not audited by a CPA. CMS has some language that says that they can audit, but again, in the 10 plus years I've been working with cost reports, I've never heard of CMS auditing one of these. And I can't believe that they do, because like I said, I've found hundreds that had horrible, obvious mistakes. They could have been caught with automated software that looks for like addition errors in columns and stuff like that. Literally, I think you can just upload anything you want to CMS and they will just stick it in the database. Not audited by CMS, which creates the problem of garbage in, garbage out. We are trying to figure out, does a specific nursing home owner need higher reimbursements? We can't even begin to do that analysis when you have such garbage CMS reporting, okay? It just, again, the old adage in computer programming, garbage in, garbage out, that's exactly the same problem we've got here. We can't even begin an analysis on some of these facilities because the cost reports are so blatantly inadequate. There is no ownership transparency. Even if we had great cost reports for an individual facility, trying to figure out which facilities are owned by the same person or company is almost impossible. I spent most of Saturday trying to piece together chains in New Jersey for a project that I'm doing in that lovely state. And I spent most of Saturday, and at the end of the day, had to just say, I can't do it. I can't figure out who owns the facilities in New Jersey. CMS has a database called the ownership database. Unfortunately, once again, completely inadequate. It may show some of the officers that are listed in that facility. It may or may not show direct ownership or indirect ownership. It may show who has operational control, but there is absolutely no consistency as to what is collected across a wide band of facilities. So it is exceedingly difficult to figure out who owns which facilities in New Jersey. And that's not just New Jersey, that's everywhere. So without ownership transparency, you then again, how do you determine if a chain is profitable if you can't even tell what makes up the chain? Which then of course complicates your related party transactions, because how do we know which companies are related to each other and should be reporting transactions between each other if we can't figure out how they're related? So again, ownership transparency is a big issue. And then of course, no financial transparency. We need better financial transparency, not just at the facility level. I've shown you how using one simple technique, you can make the income statement say anything you want. But we don't know what the assets of these facilities are because the assets are held in related parties that have no transparency, like the property, the real estate in the building. It's held in a real estate holding company. We have no idea what its value is. We obviously can't tell what any of the other assets values are because they're all held in related parties. So again, no way of telling what their asset structure is, no way of telling if a facility is actually profitable or not. So what effect does this have? Okay, why does a chain want to manipulate its financial statements? Okay, number one, the related party structure is going to be used so that you can protect your assets in shell corporations. Okay, this is straight up, law school 101. Put your major assets in a different company so that if your first company gets sued, it becomes almost impossible to get to the major assets. Okay, and that's exactly what we have in our private litigation. We go after Grapevine Nursing Center and it has no assets. It is basically on paper almost bankrupt. It's real estate holdings, it's building, everything is held in related parties that we can't get to by and large. And so it's a great way to protect your assets so you don't have to pay for your negligence. It's a great escape mechanism. So second thing, you have related parties so that you can siphon money so that you don't show a profit. And then third, this leads to understaffing, which at first doesn't make sense. And I understand that. It's like, how does related parties lead to understaffing? That seems like a complete disconnect. But let me show you how this works. Why do you understaff? Well, number one, your assets are protected. So it doesn't matter that you're committing negligence, okay? The fact that you're killing multiple people a year is not a big issue financially because the individuals who sue you can't get to your assets. So they are going to either get stuck with a small insurance policy that may pay next to nothing, or there may be no avenue for them to get justice because there just is no way to get to the assets. So there is a disincentive to take care of the clients because the facility and the company know their assets are protected, even if they're killing people left and right. Secondly, siphoning money so you don't show a profit. This becomes a great excuse to cut staffing. If I can wave a piece of paper that says I'm losing hundreds of thousands of dollars a year, I can then turn around and cut my staffing because I don't have any money to pay them. Well, the reason I don't have any money to pay them is because I moved all the money from my front right pocket to my left front pocket, meaning I moved it from the nursing home to my real estate company. I have the money, it's just not in the front right pocket. But the rest of the world doesn't know what's in my other pockets. They can only see that front right pocket and it is empty. So I can cut staffing. I cut staffing because why? Because every dollar that I save in staffing becomes a dollar of profit that I can move into one of my other pockets. So having related parties in this shell game sets up a negative feedback loop to understaff and then not have to pay for the consequences of the injuries that come from understaffing. Now, I want to show you briefly a staffing analysis that we do whenever we're in private litigation to show how profitable understaffing can be. The way you do this is you look at the acuity of a facility and you see what their expected staffing is. Expected staffing is a measure that is based on CMS's time studies that say if you have this level of acuity, we'll call it acuity level C, then you need this much RN time, LPN time, and CNA time to be properly cared for. That's expected staffing. Reported staffing is what the facility reported staffing at. Okay, there are reported staffing in the federal annual cost reports. There is reported staffing to the payroll-based journal, daily staffing reports that are submitted from the facility to CMS. And some states collect staffing information in the Medicaid cost reports. So we have different sources we can look at for reported staffing, and you take the difference to see, is this facility staffed correctly or is it understaffing? And so you start by creating a spreadsheet, because I love spreadsheets and everything works better in a spreadsheet. You've got expected staffing, reported staffing, and the difference. And now you break it down by the type of license your nurse holds, RN, LPN or LVN, and you have your aides, and HPPD is hours per patient per day. So if you have an HPPD of 1, that means it's 1 hour of care per patient per day. So we look at the acuity in our facility, and we figure out that the average resident needs 4.46 hours of care, and that's broken down by 1.23 hours of RNs, 0.65 of LPN, and 2.58 of aides. So 4.46, which means that each patient, on average, now each one is going to be different, but on average, in our facility, each patient needs about 4.5 hours of care each day. Now, let's go look at their reported staffing. And what we see is they reported 0.35 hours of RNs, almost an hour of LPNs, a little over 2.25 hours of aides, and a total of 3.57. And then we take the difference. And what we see is they're drastically understaffed on RNs by almost 9/10 of an hour. Their LPNs are overstaffed. Their aides are understaffed. And on the whole, they are understaffed by about 9/10 of an hour. Now, this is actually a very accurate depiction of what we see in for-profit nursing homes. We see drastic RN understaffing. We see LPN overstaffing in an effort to cover some of that RN time, but doing so with cheaper LPN hours. The problem, of course, is every state has statutes that say what the scope of practice is for RNs and LPNs. And LPNs cannot do what RNs do. So overstaffing your LPNs doesn't help unless you're requiring them to actually practice without an RN's license, which would be horrible for everyone involved. Now, once we know what our differences are, we can assess the value of the understaffing. And this is done by taking our difference, which we just calculated, and we go to the spreadsheet in the annual cost report. The worksheet is called S3 and the Roman numeral 5, or V. So S3-V. And on that worksheet, the facility has laid out what their average hourly wage is for RNs, LPNs, and aides. So there's no guessing what the staffing costs for any facility in the country. We can just go look at their spreadsheet and we can see this facility had this cost structure we see here, $33 for RNs, $24.50 for LPNs, and a little under $14 for aides. And so when you multiply that out, what you see is that this facility per resident, so this is for one resident, on average is saving $29 a day by understaffing RNs. They are overstaffing LPNs by about $8, and then they're understaffing aides by about $5. So for one patient, they're saving $25.74 each day. And you say, well, that doesn't seem like a big deal. That's, it's supper. That's, whatever. I'm not super concerned about $26. Well, over a year, that $26 turns into $9,000 and almost $400. So almost $9,400 per patient. So for each patient, each year, the facility is saving $9,400 by understaffing. And if you have 105 residents in your nursing home, you just saved $986,000 by understaffing. And that became profit to the owners, because since they didn't have that expense, foosh, it goes straight into the owners. So this is not a drastically understaffed facility. It is clearly understaffed, and it is terribly understaffed on RNs. But that's almost $1 million of understaffing in one facility in 1 year. And this is not an unusual occurrence. It is not at all uncommon for us to find $1 million of understaffing in a facility of about 100 residents. I do thousands of these analyses, and that is a fairly average amount for 100 facility, 100 census. So $1 million. So that's why you understaff. It's very, very profitable. And if you can turn around and hold up an income statement that says you're losing money, how could you be expected to pay for this extra $1 million of staffing? And when you kill somebody because you understaffed, all of your assets are protected. So there's not an incentive to actually staff. So there's no transparency, as we've discussed. Private equity is getting, attention these days, as it should. But this is not just a private equity problem. This is a problem across the industry. And before anybody jumps up and is like, oh, you're making general sweeping statements, yes, I am. I am a litigator of elder abuse. I litigate against bad institutions. I do analysis of bad institutions. My frame of reference is bad institutions. I don't get exposure to great nursing homes because great nursing homes don't kill people. So I'm not analyzing them. And so when I say it's an industry-wide problem, it is a big problem. There are some that should not be lumped in there, and I will grant you that. But the ones that I look at on a daily basis, there is a huge problem. It's just that private equity has made it worse. Corporate structures we discussed before. The transparency that I hate to call it transparency because it's really not transparency. So let's just say the financial reporting that we do have is on a facility basis. Grapevine Nursing Center is going to file annual cost reports with the state and with CMS. Memphis Nursing will also do the same thing. Unfortunately, as we discussed, they can manipulate those financial statements. So we actually don't have any transparency there. We will not have a financial filing for the real estate holding company. We will not have any financial filings for the management company, nor will we have complete filings for Southern Mega. Now, Southern Mega will file what's called a home office cost report, or it will show what its total costs were and how it allocated those costs. Well, total costs of Southern Mega itself. So the rent of the corporate building, the utilities for the corporate building, the staff at the corporate building, and how that was disseminated down to the facilities that it manages. What we do not have is a financial picture of the entire company. And that's what we need. The biggest questions: who owns the parent company, and is poor care due to under reimbursement or underutilization? Those are our two big questions. How do we answer those questions? Pretty easy. Number one, disclosure of all owners. And I mean all owners, all the way back to the investors in the private equity fund, okay? In our private equity fund called Blackbeard Investments, we should know who's in Blackbeard Investments so we can tell if they should in fact be owning nursing homes in the United States. That will give us ownership transparency. If we get ownership transparency, we can link up all the companies or all the nursing homes into their individual companies. We can also see if Blackbeard owns multiple mid-tier companies like Mega. Southern Mega may be one of several that own multiple nursing homes. So you have anti-competition because they own so much of the market share. Transparency of ownership will allow us to establish that. It's something that the Federal Trade Commission, the FTC, should be looking into, but because the ownership is so non-transparent, it's completely flying under the FTC radar. And then secondly, we need consolidated, audited financial statements from the parent company that covers all subsidiary companies all the way to the ground. Okay, so in our little picture that we've had here of related parties, we want to know what is the income, expenses, profitability, or loss of everything within Southern Mega's control. Southern Mega, the management company, the real estate company, all the nursing homes, we want to know what is their total financial picture. And that needs to be prepared by a CPA, and it needs to be audited. Okay? A CPA has to sign off on it that they have audited it. They are signing off that if they didn't do it, they could lose their license. So we need audited, consolidated financial statements. When we get those, we will be able to answer the question of, is this a reimbursement problem or is this a utilization problem? Is there profiteering or is there actual need for more money in the nursing home sector? Because without consolidated, audited financial statements, all we're doing is throwing money and expecting private equity and private ownership to do the right thing. And they are completely disincentivized to do the right thing. Their only incentive is to make profit. If you give them more money, they will put that money in their pocket. So we need to understand if they are making money or not. My name again is Ernest Tosh. This is my email address, and that is my telephone number. If you would like to talk about cost reports, staffing data, private equity ownership, we're more than happy to talk with you, answer questions, whatever I can do to help you understand this a little bit better.
Thanks so much, Ernie. I don't know about the rest of you, but I always have an aha moment when I hear Ernie speak. He's been a very successful attorney and lecturer. I think he may also make a great teacher should he ever decide to be a professor or something like that. We do have a number of questions here. And the last few that we have, basically asking, like, what is our vision moving forward to achieve better transparency? What do we need to do? That's part and parcel with the next question, which states that it seems like there's a clear conflict of interest between quality of care and large for-profits. Are there any actions other states have taken to address this issue? Any effective models? So I think the question is, what can we do in New Jersey? What are other states doing? Or I don't think we want to do this, but should we throw up our hands and say we need the federal government to address this? What can we do at the state level?
Well, number one, again, is the two things that we have not seen effectively from the federal government, which is ownership transparency and financial transparency. So if you required better ownership tracking and filing, that would clarify that. And then if you forced the chains to file consolidated audited financial statements, that would get you the financial. Now, if you want a model, go look at Virginia. Virginia has a model that says if you operate even a single nursing home in Virginia, you must file consolidated financial statements for your entire company. Okay, so, and that is made available to the public. So if you were to require that as the state of New Jersey, anybody operating one of your 370 nursing homes would have to file consolidated returns. And I think part of that is also any legislation that addresses ownership and or financial filings needs to be very specific that this information has to be made available to the public. The reason I say this is because the home office cost reports that I mentioned briefly in my presentation, I used to be able to just Freedom of Information Act, request those from CMS and get them. I could see all the facilities that that company was listing as their chain and how they were allocating their expenses. The problem is, about a year and a half ago, CMS, and I have no idea why, decided that that was trade secret and will not release that information publicly anymore. So the only opportunity we had to figure out who owned a chain, we lost that. So when you do this type of legislation, you have to be very specific that this information has to be released to the public.
Another question we got is it possible that assisted livings are also owned by private equity or have similar potential problems with profit taking?
Absolutely. And it's even harder to tell in assisted living because most states don't track assisted living because they are not part of, traditionally not part of the Medicare, Medicaid system. They don't get federal and state funding from most states. So like in the state of Texas, where I am, we have virtually no regulation of ALFs. Not only do we not have financial filings for them, we have no financial filings for them. CMS has no financial filings for them, but the state of Texas has virtually no regulations. So absolutely, you're going to have private equity come into that sector because you have cash that's basically untraceable. The families are paying you gobs of money and you don't have to answer to anybody for it.
So I thought it did apply to assisted living. So how would just a consumer know or find out about ownership of an individual nursing home that their loved one is in? Like, what can they do?
So unfortunately, CMS does have the CMS Compare website that does have some information on it. Unfortunately, the ownership information is tied to CMS's ownership database, which, you know, I beat up pretty heavily in the presentation. And that's as good as it gets. They could, if they really wanted to as a consumer, contact the state and see if the state licensure folder had more information. But let's be honest, they're not going to do that. I've never heard of somebody doing that. I teach attorneys to go get that information in litigation and have to beat them to go get it. So you can't expect a family to go do that. And as far as mentioning CMS's Compare website, I feel obligated to tell you that whole thing is a disaster as well. The 5-star rating system is a complete dumpster fire. And so I hate to send people to that website because I know they're going to look at those ratings and think it's like a Yelp rating and be like, oh, look, it's a 4-star facility. Great. Yeah, it's all crap.
I have a question here. You know, what about the standalone facilities that are staffing as mandated, complying with quality measures, and find it hard to break even?
I think that probably does exist. I'm not, like I said, I deal with the worst of the worst, and so I do admit that my scope and my thought on the subject is somewhat jaded. I do believe there are some smaller organizations that probably do have financial issues. And I think part of the issue there is they don't have the economies of scale that someone like ManorCare or Genesis has. So they are not able to cut their expenses using economies of scale, meaning they can't purchase in bulk. And so they're not able to compete on the same level as a ManorCare or Genesis. So I do believe that does exist. And I think if we had transparency across the entire market, we could help those facilities.
Right.
Because there are facilities out there that are trying to do the right thing. And they may need more reimbursement. And I'm very open to that. I'm not opposed to reimbursing companies for providing quality care. My big complaint is giving companies buttloads of money who kill people and just take the money and run. I have a real problem with that.
Yeah, and another question was CMS is either overwhelmed or seemingly inadequate. How can we influence CMS to take action on complaints and take this more seriously or be more responsible in terms of this economic stewardship here?
So I think anytime you get the federal government involved in regulatory matters, you run into that giant, quagmire that is a federal bureaucracy. And CMS is a combination of inept and probably underfunded. It's politicized. I mean, the difference that we saw in dealing with CMS under the Obama administration versus the Trump administration was night and day different, amazingly different. So it is highly politicized. So trying to motivate CMS to do anything, I don't know that you can. I literally sued them for 3 years to get hold of some data. It cost us a fortune. And it was because under the Trump administration, they just decided they didn't want to give it to us. And so they spent hundreds of thousands of dollars on litigation that had no purpose for them. So trying to get them to take something more serious, to do better surveys, to employ more people to oversee nursing homes, I don't know that you can do that. I don't know that CMS is the answer. I personally believe the answer is the state government. I think this is an area where the states have to step up. Virginia stepped up. California is stepping up. I think the states have to step up and go, you know what, this is broken and we will fix it in our state.
Another question we have is, can't we address the symptoms, staffing, low staffing, with stronger penalties that begin to ensure that companies will at least staff to standard. So I think that's the question: is can't we enforce it? I could probably answer that, and that is
Right.
whack-a-mole, trying to the staffing complaints that you're getting. Go ahead. I mean, can you?
Sure. The problem with the surveys as they currently exist and that deal with staffing is that you're expecting a surveyor to go in and look at a facility for 3 or 4 days, maybe 3 or 4 days in an entire year, and then give them a thumbs up or a thumbs down on their staffing. Well, that's easy enough to staff up while the inspectors are there. So then you're saying, okay, well, why don't we go back and see if they staffed appropriately? Well, state minimums are one thing. The New Jersey state minimum is not good enough. Number one, it's too low. And so if they are staffing to the state minimum, they are not going to have the necessary staffing for most of the residents in the facility. So staffing to a minimum is not enough. What you really need to do is staff to expected, which means if you are taking higher acuity patients, you need to increase your staffing to meet the higher acuity. And so if you require that, then your inspectors need to have a way to do that comparison. What is the expected for this facility? And what is their actual staffing? And is that sufficient? And as I laid out for you in my presentation, that's actually fairly easy to do. It's just we're not equipping regulators or inspectors to go out there and do that right now.
I think we do look at acuity, but yeah, I mean, I think that is the most common complaint we get, right? And I think what you hear from the industry side is we can't recruit people to work here. We can't get enough nurses. We can't get enough LPN CNAs. What is your answer to that? Why is it that this industry cannot attract? Is it that they can't afford to pay higher wages and create better working environments?
Well, I think that, when you look at their financials like we do, you can easily see why they're going to make that claim. That claim is based on the fact that they can't hire people at substandard wages. Walmart can complain that they can't get enough people to work if they're only offering them $3 an hour. Same kind of thing. If you're only offering a RN, $25 an hour in a market where $45 an hour is standard, then no, you're not going to be able to hire enough RNs. But if you pay them competitive wages, then you will be able to hire them. And that goes for your CNAs, which I think CNAs is probably less of an hourly wage thing as it is overworked and injury ridden. CNAs, I think, have one of the highest incidents of injury in long-term care directly due to understaffing. And so I think if you increased your staffing level, so your CNAs aren't getting hurt, you paid competitive wages, you could get the spaces filled. And the only way for us to understand if the facilities can do that is if we have financial transparency to understand what their finances look like. Because right now what they're going to tell us is we can't offer more money, we can't pay higher wages, we can't get anybody to work here, we're screwed, we need more money. But at the same token, they won't show us what's in their pockets.
Right. I think that's kind of the larger theme here is if the workforce issues can be addressed by increased Medicaid funding or Medicare funding, okay, that may be the case, but where is the money going, particularly in the private equity sector?
Exactly.
The question was asked, which dovetails into that, what about the nonprofit sector? I think they probably have more transparency and less of an incentive to do this kind of stuff. And I know that generally care is better in the nonprofit sector, but we did get a question on that.
I agree with your comment there. We very seldom do analysis and litigation involving nonprofits. It does happen occasionally, but it is few and far between. I think and that's the advice that I give individuals that contact me about, hey, I'm having to place a family member, or I got a client that we need to place. Can you direct us to a good nursing home? And, my first comment is, if I know the nursing home, it's not a good one. so I direct them to nonprofits. Go find a nonprofit, go inspect it, and see how it looks to you. Talk to the facility administrator, talk to the director of nursing, and see if you feel comfortable about it. Because the nonprofits traditionally do a better job. And I think that really is telling that the nonprofits have better staffing, better outcome numbers. Why? Because they're not concerned about making all the money and sending it up to an ownership. They're there for care.
And of the ones that have closed really since COVID, more of them are the nonprofits. There's no doubt. So clearly something's going on there. Another question we have is, are there known benefits to a state that would lead a state to approve the ownership change of many facilities to the same owner? That kind of like a scenario where they look like the savior coming in and buying all these at-risk facilities, but in fact, maybe they're not. Maybe they're private equity. Maybe they're in it for the short term.
Right. And the question is, is what can be done about that? Or
well, have you observed that? I mean, the question was, why would a state allow a large number? Like we've seen it here.
Sure. And
like approving, and an ownership goes from 3 facilities to 25 in a year.
Yep. Yeah, Porto Piccolo is an example of that. That's a private equity group that's operating pretty heavily in North Carolina right now, where they, as far as I know, didn't even exist 2 or 3 years ago. And now they are at the forefront of the number of facilities they're purchasing. Now, why would a state allow that? Well, a state, is limited in what they can deny applications for. So if you are a legitimate company that has the right structure and the right leadership, and you've got financial resources, and you haven't been disallowed from the Medicare Medicaid services, you're probably going to pass and get ownership. The fact that you're a private equity group is not a reason to disallow you from owning nursing homes. Unfortunately, as we've seen, private equity does not particularly care about patient care. They are there for profit. And so when they come in as these saviors, what they can turn around and do is strip all the assets out of the company and leave it bankrupt, and they still made money. So
well, that's kind of what we had, that question.
Situation.
Why if it's profitable, does private equity only get in for the short term?
No, because it's profitable in the short term for them. But when you're looking at, okay, let's back up. Let's look at like life care. Forrest Preston has been in the nursing home industry for 40 years. He's long-term. He owns, 70, 80, 100 facilities now. It has been very profitable for Forrest Preston over his lifetime. Private equity is not concerned with the lifetime. They're concerned with 4 to 7 years, and they want to make a return that is so high they can't get that return anywhere else. Okay, you can't double your money in the stock market in 4 years, but you can double or triple it in the right investment with private equity. So they're going to come in and they're going to do things that are highly detrimental to the long-term survivability of a nursing home to generate that high level of profit. And one of the things they're going to do, and I don't want to get too far down this road, is they can take out massive loans against the nursing home's future income streams, immediately realize the money from those loans, and then walk away from the nursing home. It bankrupts the nursing home, but the private equity investor walked away with hundreds, thousands, or millions of dollars. So they can do the same thing with long-term assets such as real estate. So again, my longer presentation goes deeper into those subjects, but there are ways for them to pull out basically long-term assets, sell them, and basically put the facility in a very precarious situation going forward. So precarious that it may not be able to provide adequate care because it is so heavily strapped with debt that it physically can't make its debt payments and staff. And so it's a bad situation, and that can be fixed, but that's another phone call.
Right. And I know we're right up on the time, but I do have questions. And I guess basically a couple of questions. People want to know, how would I know if the facility is nonprofit or if it's private equity? I mean, you can go on the Department of Health website. They do have a facility search provision on the Jersey Department of Health website. I will say when you go on there, sometimes there's just a lot of names, and you don't know, and those names can show up attached to other facilities. So I think you found this out when you were looking at New Jersey, Ernie, right?
Mm-hmm.
You have a lot of familiar names out there in different and part ownership stakes in different facilities. It is difficult to figure out. I think it's pretty clear who some of the nonprofits are. Finding out your facility that your loved one is in is private equity as opposed to a publicly traded company. Is there, do you
Yeah,
Google? What do you do?
That you can tell. Okay, so let's back up. How do you know if it's a nonprofit or not? Well, the New Jersey website and CMS's Compare website will tell you if it is a for-profit or nonprofit on the front page of USA or the CMS Compare. It's on the front page. It'll say nonprofit or for-profit. So that you can figure out fairly quickly. Now, whether that is a privately owned facility or a publicly traded facility, you would have to go, you would look and see, okay, well, that is a Genesis facility. Well, Genesis used to be a publicly traded company. So if you saw Genesis, you could then go look at its SEC filings and see if this facility was in fact listed as one of its assets. But guess what? Genesis was purchased by private equity. So that no longer exists. How do you know if it's a private equity versus just a private ownership? Can't know unless you are really, really deep into this subject and know who the private equity guys are. And you know, there's not that many people that are that deep into this.
I mean, this is just an observation. Somebody said her father and his peers have been told that juice and other simple foods have been eliminated from their diets because of budget issues. So she's thinking he's in private equity. What can
That's probably a good guess.
That even be true, but you know, that's anecdotal. But you know, you do hear that all the time. Totally strapped for cash. May be true in some facilities, maybe not so much in others. What can we as private citizens and those of us who are policymakers, what can we do? Who do we need to talk to and maybe share this webinar with to say, you know, we need more transparency around who the ownership is and what the profitability is. We have taken some steps in this direction in New Jersey, and there is a question here about the current law that we passed, which does require greater transparency, some financial disclosures by individual nursing homes. I think if we're listening today, we're hearing why truly seeing the financial disclosures of an individual nursing home does not tell the whole story. So what in the kind of succinct way, what should we be asking our policymakers in New Jersey to be doing?
Well, I think number one, from the citizen standpoint and from advocates standpoint, is we need the individuals that are making policy to understand that they don't have a full picture, okay? This goes back to our comments over and over again about transparency. we don't know if the facilities need more money. We don't know if they're profiteering. We just don't know. And we need our policymakers, both in Washington and at the state level, to understand that they have a lack of information and they need more information before they spend more money. That's number one. How do you get more information? Talk to people like me, Dr. Gupta, Dr. Howe. We can help them understand the issues and then help them frame legislation that will get better transparency. So I think that's the big thing. If you're an advocate, if you are a family member, contact your representatives at the state level and the federal level. Send them a link to this. Send them a link to Consumer Voice. Send them Dr. Gupta's article and let them start to understand that they're only getting one side of the story, and that's the industry side, and that side may not be true.
I think we should probably wrap this up. We took you a little longer here, Ernie, but I think this, I can't tell you how much I appreciate this. The comments are really good. Ernie makes himself he's so generous with his time and his expertise. I thank you so much for the time that you gave me. You know, I contacted you, gosh, 6 months ago, and then I saw you were going to be a Consumer Voice, and I just love how you walk through this stuff. Again, what I was saying in the beginning is there are things that state policymakers can do. There are providers out there who are at risk and perhaps do not have the funding that they need and are trying to do things the right way. And so we don't want to talk with the same brush, right? But the fact is that we are seeing an increase, and this includes right here in New Jersey, in private companies taking over nursing homes. And as Ernie said, some of these they would not be in this business if there wasn't money to be made. It's particularly true on the private equity side. So as we talk about reforming this system, as we must do, Medicaid is a huge player here because it is a huge payer source here. And there are things that we can do and should do, it seems to me, you know, down the road to look at how do we really right-size this system? How do we support, you know, keep in mind, we also need to support the expansion of home and community-based services, right? And so we've got limited Medicaid dollars, state dollars and federal dollars that you're talking about spending. You need to also keep in mind that one of the ways to reform long-term care writ large is to support home and community-based services, right? So people don't ever have to go into a nursing home, many of which have become very large, relatively unsustainable institutions, and keep people out of those institutions, allow them to stay home, or identify people who are in these institutions who might want to move into the community if there's affordable and accessible housing and community supports for them. So when we talk about long-term care in general, we're not just talking about nursing homes, because they are a critical piece of it, and they certainly are what we were talking about today. But we have to keep mindful also that Medicaid funds home and community-based services, and as I said earlier, has some very ambitious plans to utilize state and federal funds to expand that as well. So really appreciate all of your time and your questions here. You see Ernie's number, you see his email. He's a teacher, he will teach you, he will inform you. I just want to thank everyone. Thank you so much, Ernie.
Oh, absolutely. I appreciate the invitation.
Take care, everybody, and thank you for tuning in. We will make this available on our website. We will make the PowerPoints available also on our website. So look for that on the Long-Term Care Ombudsman website coming up. Thanks so much, everybody. Bye-bye.
Thank you.